regulatory side of things, this is from the IDPH guidance, which is speaks to and references the CMS regulations related to visitation. Facilities should not restrict visitation without reasonable clinical or safety cause, and it's consistent with the 42 CFR. And facilities must facilitate in-person visitation consistent with applicable CMS regulations. And so the residents who are on transmission-based precautions for COVID we do want to limit those visits, obviously, but they can receive visits virtually or in person for compassionate care situations while adhering to the transmission-based precautions and wearing necessary PPE. But once that's lifted, then when the transmission-based precautions are lifted, then per CDC, then other visits could take place. I wanted to go through what we've been sharing with long-term care, just so you will be aware of that. So this is an outbreak response in long-term care when they identify a positive case in a resident or staff member. We are asking them to pause indoor and outdoor visitation, communal dining, and group activities on all units or throughout the building until that first round of facility-wide testing is completed. Now, if you look at CMS document, there's some verbiage in there that says based upon state guidance, et cetera. This is what the state of Illinois has decided. We felt like with the turnaround of our testing and the capacity of testing throughout the state that this would not be a long wait. So it would be best to determine the extent of the outbreak. So we are telling people to pause until they complete that first round of testing. We felt like that was important, and they should pause indoor and outdoor and the activities, et cetera, for that time period. So when the new case is identified, indoor and outdoor visits, except for the compassionate care and end of life and representatives of the protection and advocacy systems should be paused. So there is some leeway a little bit there with compassionate care, end of life, and then of course, representatives of the protection and advocacy system. So I don't know what you're hearing. I'm sure we'll hear as soon as we go through the slides what you're seeing on the other side of things, but that would be good for us to hear that feedback from you as well. Compassionate care visits and visits required under the federal disability rights law should be allowed at all times, regardless of the resident's vaccination status, the county's positivity rate, or if they're in an outbreak situation. Deb and I have been encouraging this, and I feel like we've kind of gotten on our soapbox or whatever you want to say with this and have been trying to hammer this home. We hear that some facilities are still denying access. And so we've been trying to ensure that visits are occurring, but I don't know what the hiccup is. I don't know what is preventing some of these facilities from allowing visits, but we have heard periodically that there are some facilities not allowing compassionate care visits, which really should not be happening. This looks like a checklist, the format, and we're trying to put this into the actual IDPH guidance. This template has been approved through the IP team, the infection prevention team, and Dr. Kennard to put in the updated guidance, but that has not been released. So on May 6th, IDPH released the new updated guidance. This would be an update to that. The content is not new, but it was more checklist based. In other words, do this, do that, then do this, do that. Facilities struggle with all of the change in documents over the course of the pandemic. It's been really difficult for them to know. A lot of them will voice that they're overwhelmed. They're not quite sure what they should be doing. And so this was an attempt to hopefully help them navigate through a newly identified case. What do I do next, et cetera. So some of this is redundant from what I had just shared on another slide, but I'm going to go ahead and read it to you so you can get a feel for what we're sharing with them and what it should look like. So when they identify a new case, it is considered an outbreak. CDC states that they should be wearing N95 respirators and eye protection on all units until there are no more positive cases for 14 days. So that should be happening, even with one case. We ask that they pause the indoor and the outdoor visits, communal dining, and group activities on all units until that first round of testing is completed. Complete that facility-wide testing. Continue to test every 3 to 7 days until there's no new positives for 14 days. And then we do have the caveat that residents or staff within the 90 days of their active infection they can be excluded from the testing. They would not need to be tested. From that point, then they're going to be able to evaluate whether the outbreak is contained to one unit, which we're calling the affected unit, or if there's been transmission and it's spread throughout the building. If it's contained to one unit, the remaining units, which we're calling the unaffected units, may go ahead and resume the indoor and the outdoor visitations, communal dining, and group activities, following guidance specific for vaccinated and unvaccinated persons. Now, I did not go into what that means here, but that has to do with being able to, the vaccinated individuals could remove their mask, don't have to worry about social distancing, et cetera, whereas the unvaccinated individuals would need to ensure that they're still maintaining that physical distance between one another. And then of course they should keep their masks on. And then there's also some guidance in there that when it's group activities, that if you have an unvaccinated individual present, everyone within the group would need to be wear source control, although the vaccinated individuals could still sit closer together. Okay, staff must continue to wear the N95 respirators and eye protection on all the units. Gowns and gloves are used per standard precaution when caring for all residents on the unaffected units. Okay, I can't get it to advance. All right, I'm gonna.
It's okay. While you're doing that, the one thing I was going to say is if you happen to read, this is Deb, if you happen to read the CDC guidance, you will notice that it says something about full PPE in the entire building. Well, we had a long conversation with a bunch of the people at IDPH and sort of came to the decision that gowns and gloves should be used as in standard precautions so that we don't have people all over the building trying to figure out what they're supposed to do with gowns, and just focus on neck up.
Yeah, and that's in this next slide here. So then this is moving on. So these are things what should occur on the affected unit. So this is where the outbreak occurred. They're going to suspend indoor visits until there are no new positives for 14 days. Residents with a higher risk exposure to the positive case should be placed in quarantine and restricted to their room, and ideally that should be a single room. Residents with high risk exposure may shelter in place or be moved to an observation or yellow zone, placed in quarantine and in a single room. And residents that did not have a higher risk exposure, or we're calling those the unexposed, they are allowed to participate in outdoor visits. Source control must be worn when walking through the building to get to the outdoors. So these are on the affected unit. So the case occurred on this unit, but maybe I reside at the end of the hallway. I've never run into that other person, etc. I am still allowed to have outdoor visits as long as I wear source control as I'm exiting the building, but I can't have anybody inside that space because for lack of a better word, we'll say that floor's contaminated or it's had the exposure on it. We wouldn't want somebody else coming in to that floor, potentially exposing them to that virus. So the unexposed residents should not participate in communal dining and group activities in the main dining hall or activity hall. However, if that affected unit has a separate area for dining or activities, they could participate in dining and activities on that unit, following the guidance for vaccinated and unvaccinated. And I know that sounds kind of confusing, but Deb, what did you call it? Neighborhood
households or neighborhoods, if you have a unit that has its own dining room and its own activity area, is that what you're talking about? Then,
Yeah, a
as
lot of
long
them
as
are
the
going to
cohort
that.
stays together.
Yeah, yeah. So we don't want these people, because they've been they live or reside on the area where a positive case was identified. We don't want them mingling with everybody else throughout the building, just in case they were to come up and develop the illness at a later point in time. Okay, full PPE. And what does that mean? That's the N95 respirator, the eye protection, the gown, and the gloves should be worn for residents who are placed in quarantine, or for those that are suspected or confirmed for COVID. And this is what Deb was alluding to here. Staff must continue to wear the N95 respirators and the eye protection throughout the entire building, but the gowns and gloves are used per standard precautions when caring for residents on the affected units, unless they're in isolation for another diagnosis. So if I am on the affected unit and you're taking care of me, and I have not had a high risk exposure, you would only need to wear an N95 or eye protection, unless whatever, maybe you're doing wound care or something like that, that person would need to determine, is there going to be sprays, a splash, anything like that, that they might contaminate their uniform, that it should be best to wear a gown? Or am I in isolation for C. difficile or something else, MRSA, that you would be wearing a gown to care for me anyway? Then of course gowns would be necessary. So if more than one unit is involved, then the facility must suspend all indoor visits until there are no more positive cases for 14 days, except those required by the disability rights law, end of life, compassionate care, etc., and allow outdoor visits except for those who are placed into quarantine because they've had that high risk exposure, or it's a newly admitted unvaccinated person, or I'm in isolation for suspected or confirmed COVID. Those are the ones that should not be going outdoors for visits. A reminder slide of who should be in quarantine. It should be the unvaccinated new admissions or readmissions, symptomatic residents who are awaiting their test results, vaccinated or unvaccinated who've had a higher risk exposure, and then that's within the 16 feet, 6 feet for cumulative time of 15 minutes or more in a 24-hour period with someone with COVID-19. If they're unvaccinated residents who leave but may need to be quarantined based upon the risk assessment, and that is available on the IDPH webpage for long-term care resources. And then unvaccinated residents who leave for greater than 24 hours, they should be managed as described in the new admissions and readmissions section, which means if they're unvaccinated, they would definitely need to quarantine. And then if it's a roommate of a resident with SARS-CoV-2, then they should be considered exposed and potentially infected, and they should not share rooms with other residents while they're in quarantine, which is through the 14-day period. And that's all I had. So, Deb, do you want to add anything else? And then we can start taking questions.
I
That's
think
okay with you.
you did really well. I don't think you have anything.
Slides. I just wanted to touch base as far as, those are some of the biggest slides that we kind of walked through. I wanted you guys to know what you should be seeing. So when you're walking into the building, if they're an outbreak and they're an outbreak, you should be seeing N95s and eye protection on every single person in that building. That was one thing I wanted to make sure we touched on. The other thing was, you need to know if they're an outbreak, your question should be, is it throughout the building, or is it only on one unit? That should be a second question, because you're going to need to know that. And because along with that becomes if it's the affected unit, then you're only going to have outdoor visits for those people, right? Unless it's compassionate care or end of life. On the unaffected unit, it can be both indoor and outdoor. So that's where I was going with that, and trying to separate that out. So if you see different things, just so those would hopefully answer your questions, or make it more sense as what you may be seeing.
That was very, very helpful. very, very helpful for us to see that, because we are hearing people are seeing different things. And
Okay.
sometimes we're not understanding the differences between outbreak and not outbreak and all of those pieces as well. So Karen, thank you so much for sharing all that. We have a lot of questions
Okay,
that
great,
are popping up.
Okay.
So what we'll go ahead and do is we have Teresa and Stephen are our two ombudsmen that have volunteered so graciously to help be the voice for those questions that are in the chat. So Teresa and Stephen, do you have questions you'd like to share with everyone?
They started right away. So right at the top, when a resident is not feeling well, how can we prevent the resident automatically being placed in isolation?
This is really fascinating because I just got off a phone call with a facility who, now we're all trying to do the right thing to make sure everybody stays safe. But I just got a phone call for a facility that's in survey. They're not in outbreak, they're in survey. And they have a person with a dry cough, and it took everything that they could do not to get cited because they didn't put the person in transmission-based precautions because they had good documentation. This is the whole thing. They had good documentation of why this person was not put in precautions, but the surveyors felt that they should have been put in precautions because they had symptoms. The facility worked through it. That's a really complex question, and it's much harder than you would think. It's one of those things because people are most infectious early on with COVID, and because these symptoms can be so strange, they can be so wide-ranging. You may see for a while, and I'll be perfectly honest, you may see for a while people erring on the side of, we have some vague symptoms, this is not baseline, then they need to be in transmission-based precautions. And as an infection preventionist, I can tell you, I would fall, unless you had really well documented symptoms like this one. That's why I brought up this case, because they had it well documented. It was a chronic situation. It was on the care plan. And that's why it didn't go any further. The physician could speak to it, the medical director could speak to it, but I will tell you, any sort of new symptoms right now, I think probably erring on the side of caution. And I just think it's probably prudent at this time. Karen, what do you think?
Yeah, and continued monitoring of that person. So we should err on the side of caution, put them in transmission-based precautions. If they're symptomatic like that, test, see what the test result, and then we get into the complex part that Deb mentioned. What's the county positivity rate? What's the test probability? All of those other things. What are the other dynamics going on?
And
has there been a recent case? Are they just a new case? Are they the one? Are they the possible start of this outbreak or not? Do they have a history of allergies, et cetera, et cetera? Because early on people were thinking, oh, well, it's my allergies, right? It's springtime or whatnot, or now fall coming on. I have fall allergies. Well, then if you don't take the necessary precautions, you could potentially miss the boat. And then we have a larger outbreak on our hands, and then it's problematic. So they should do the right thing, put them in as a suspect, test, monitor, continue to monitor. And then if the physician can substantiate that, like Deb said, chronic issues, et cetera, care plan that, then that's a different story.
Yeah, I used to tell activities, dietary, housekeeping, that anybody could let the nurse know and they could go on transmission-based precautions, because a lot of times, you guys know, it's not necessarily the nursing staff, it's the other staff that really has a good relationship with a resident and knows when there's been a condition change. The other thing that's just a heads up for this group, an email crossed over my path this morning. There's another virus called respiratory syncytial virus, which can cause, we used to think it just caused illnesses in kids. RSV is what it's called. There's an uptick in it, and they noticed this in Texas. That's the first place we saw this, was when Texas relaxed all its masking. Well, these basic infection prevention strategies work against RSV, against influenza, against COVID. So if you start relaxing them, you know, we also have to have on our radar that, you know, if you have allergies, it may be another virus, not just, you know, you're vaccinated so you don't think you're going to get sick. Well, there's lots of other things out there too. So erring on the side of caution in this case for any symptoms is probably wise and prudent until you figure out what you got.
Hey,
And I
Deb.
think that's a good reminder, what you guys are reminding us of, because, you know, I think many of us are tired of this.
Oh,
And so, especially those that have been living in the long-term care communities and they just want to say, we're done with it. And then, so the reminder that it just takes one person with one communicable disease that could get something started in our building is a good reminder for us all to take to heart and to remember that it can just take one that can start an outbreak. And so we do have to err on the side of caution. So thank you for that reminder.
Right. That actually, even though that answered the first question, I kind of wonder if it's kind of stitched into this next question. Can you explain why some facilities are closing their entire campus, even if they have multiple buildings?
We're trying to address this facility by facility. We have some good, oh, Karen, what do you call it? You know, ones we've done before, basically what we've been telling people that if you don't, here's Teresa, here's the point. Do they cross staff?
yeah.
Because if they cross staff, then it's one big cohort. It's why, but if they have, there's certain buildings that we work with frequently where all of the staff stick to one building and stick to this building, so they can treat them as individual cohorts. They don't have to do that. But there are others where if the nursing staff, if you've got a nurse that passes meds on PMs and goes building to building to building, all bets are off. You know,
Well,
does that make sense?
And we even in our guidance talked about if you have agency staff or if you have, I'll use rehab, I'll use the PTs as a good example. They may go to all buildings. And if that's the person that's positive, it kind of sets you up for an issue, right? And they were with each resident for longer than 15 minutes because I was doing, you know, in-room PT or whatever, whatever that looks like. So we asked them to do some contact tracing and go back. Where did that person go? Did they go to multiple buildings, et cetera, and kind of, you know, trace it backwards and see what they can find out. So that could be what you're seeing. It doesn't necessarily mean it could be a building that's just saying we're locking everybody down too, but that's what we've tried to share with them. If there's no crossing over of staff, you could function independently. So
Yeah.
So if we were to get that phone call from somebody saying, so my mother lives in an assisted living of a continuing care community, and the nursing home had a case, a staff member tested positive, and so now I can't go see my mother in the assisted living, but she always has the same caregiver. They, you know, they have their staff that's completely separate all the time. That's been confirmed to me multiple times. What should be our response as the ombudsman to that person and to that facility?
We've been asking some people to just reach out to Deb and I, either via email and let us know when that occurs, because unfortunately, we have talked to individuals and said, we may have to reach out individually, Deb and I, and say, you're going to need to update us on this because we're not sure why this isn't happening. I know we've gotten some information from some other advocacy groups that have shared, you know, compassionate care visits or essential caregivers, things like that are not being allowed. And that's not okay. And we're
Exactly.
preaching that every Friday. That's not okay, you guys. So we need to know. I've said to Deb, it's time. Somebody needs to just say, building X is doing this, and we will call them.
And we have been calling them. We have been calling them.
And let me say something here. So, and Deb and Karen mean this. I send them messages repetitively on your guys' behalf of, will you call this? Will you do that?
You were on. Yes.
Yeah, and we do.
Okay.
I almost said your name, Carrie, and I thought, no, I better not. So I said advocacy group. Sorry.
That's okay. No, you're fine. But seriously, or contact me and I'll get hold of Deb and Karen for you guys.
Yep.
But they are really, truly our best advocates through IDPH to help fix this. Okay. Yep. and I argue with everybody at IDPH, but I don't have to argue with these two. And I'm
Well-
so thrilled to see your faces.
Well, we try, that's the whole thing. The goal is this whole risk balancing and this risk benefit thing. And Dr. Ezike has even said it. We're right now, because the positivity rate is so low, we need to take advantage as much as possible, getting people outside in the night weather, getting people visiting, doing all this other stuff, because Lord knows what's going to happen in the fall. And so I've had a lot of,
We've been rattling the cages, so to speak.
we have been.
We've
and-
been saying, guys, stop this. And I don't know if, I kind of thought I saw something pop up in the question, but Teresa, I may be stealing your thunder here. But in the updated guidance, we're also pushing to get rid of the scheduling, the timeframes, and some of those things, because that's been a stumbling block for, well, I'll say stumbling block or a
convenience.
convenience for the
I didn't
facility.
say that, guys.
Yeah, so that they don't have to let anybody in and they only allow you to come in for 15. We're trying to get those crossed off the next update and just taking them out of it's not
Yeah.
done yet. So, we're just telling you this, that's where our hearts are and where our heads are and what we're trying to do. Those sentences are going to be removed because it's time that now that they've been able to navigate through where we're at today, they should be able to handle people in the building at this point in time.
Or outside.
Yeah, or
I had a
outside.
question. I had a question that came directly to me. So Teresa, I'm just going to interrupt you for a minute because I want to make sure that it got asked. Is the facility required to disclose any new cases to residents and families?
I thought that hadn't gone away.
That's,
Yeah.
yes.
That
They
hasn't
do.
gone away.
So
Yeah.
they
They
are
do.
required to let everybody know. Okay.
That
Also, they're supposed to be providing some type of a sheet, and I believe the guidance actually says, and here we wrote the darn guidance and I can't quote what chapter and verse, but I believe the document says, and this was from CMS, they're supposed to provide you with some type of information sheet and inform you, and that's the key word there, that if you are choosing to come in, that there's COVID in the building, then you could be setting yourself up, to potentially be exposed,
Robocalls too.
So
Robocall.
I can
Yeah.
tell you that doesn't go on. I mean, they'll tell you there's COVID in the building, or because they'll tell you they're an outbreak, but they're not telling you, hey, when you walk down the hall, you want to go this way because it's there. They are just, they
Well,
might
I
tell you
don't
it's
know
in
if
the
they
building.
It's marked.
Terry, I don't know if they can be that specific.
Okay,
because
that's fine.
it'd be like in any other, let's say MRSA or C. diff. I can't tell you
That's
that
correct. You're correct.
Joe
Okay.
has MRSA, but I can put an isolation sign on her door so that every caregiver knows what to put on, but I can't tell you, otherwise it's HIPAA.
Okay, no, and you're correct, but I think that's what they were asking. Is
Oh,
facilities
no.
aren't giving
They
them
just
any
have to
clue.
say that there's COVID in the building, and if it's say cases were to increase, they're supposed to say that more cases have been identified. They're supposed to keep you in the know as far as what's going on in the building in that regard, but not people, not names, that kind of stuff.
Right. I'm going to step in for a second. I know it was probably Stephen's turn to ask a question, but I'm just going to want to try to move things along so that, because we do have a lot of people adding things at the end, so I want to try to get through as many as we can. Do these newly allocated or newly allowed visits include any vendors completing required assessments for, I'm identifying acronyms here, required assessments for managed care organizations such as Illini Care, Meridian, Molina, Aetna, comma.
I didn't know what that
Also-
means.
I know. And then the other acronym was HRA, which is Health Risk Assessment, which is required annually for members.
What do
So
they do? Is this, I'm not sure, are these tours that they come in to inspect to make sure that like if they accept that type of insurance for post-acute?
I can
care?
help you with that.
I'm
Thank you,
thinking it's not
Carrie.
allowed in is what I think that's
So-
what's asking.
I can tell you that like our Molina rep, we have a case coordinator, and she physically comes in and usually at least once a year to lay eyes on Lynn, to look at his charts and to make sure all of the ducks are in a row.
I didn't,
So
okay.
is it per person? It's by individual recipient or building?
Usually, so like I know ours, so most of the time she'll come in and she'll do one at a time and then leave.
So
Yes,
it's like case, you know,
It is case coordination, yes.
case coordination.
Sherry,
I would say
we're
those
gonna have
people are-
Madeline.
I would say
Madeline
those-
Riley asked the questions, so why don't we have her clarify what she was asking? I just asked her to unmute herself.
yes, I'm sorry. So I work for a company that has nurse practitioners, and we actually provide a vendor service for some different MCOs, and the MCOs being, you know, different ones that I've listed. However, we have not gotten clearance yet from anyone on down to say that we are allowed to come in and do visits, because at one point non-essential visits were kind of, you know, we were told we needed to do things electronically, or telephonically. However, yes, these HRAs are absolutely required in-person assessments for any member who is covered by that payer source. So these are done annually. These are done with any changes in condition. And the basic point of them is to hopefully, you know, ensure that certain things are being done. Let's say there's like a health gap in there. They're a diabetic and they need an A1C drawn, you know, typically that's recommended every 3 months. And let's say the medical director hasn't been ordering that, you know, our nurse practitioner may see that and go, okay, we're going to turn in the med list so that the MCO knows the med list, their current diagnosis. We're trying to help manage their care and case coordinate with their care managers.
Okay, so 2 things. Telehealth's become a big thing. Do you have access to their electronic health record?
We do not. And
Okay.
so you have to be credentialed at every single building. So there's no way we could really realistically get all of our providers credentialed with their electronic health records. So we have very little access. We are relying on a telephone interview with the staff usually. And of course, as you know, everyone is short-staffed. We have a lot of visit nurses, you know, meaning travel nurses, temporary staff, agencies that know very little about these residents.
Is this part of your contract with, is your contracts with the resident and not
Our
with the
contracts are
facility?
with are with the MCOs. However, the MCO's responsibility is to HFS.
Okay, so Karen, here's what I would say. We know the value of eyes on and boots on the ground and eyes on what's really going on.
Absolutely.
Having done iCars for 5 years, we understand that. It would be my suggestion, if this were me and I was working at a facility, that I would hold you to the same standard that I'm going to hold my staff, that I'm going to hold my therapy department, that I'm going to hold anybody else to for screening, testing, vaccination. And then I don't see why that wouldn't be appropriate. Karen, do you?
No, I was going to go there too. My only other thing, and again, I don't know how feasible this would be, but maybe if a call is possible, if they're in non-outbreak situation, that's your best bet. And then you don't have to be, you know, kind of removes one obstacle, one hurdle. But I agree with Deb. To me, it's part of the you need it. It's required. And I would think the building would almost welcome that if it's their part of their payment source. So
Absolutely.
I would think that was be considered essential.
I would
But you do
consider it
have to be
essential.
screening, testing, all of those other things as well.
Absolutely.
So I had to call my office mate and ask her that question. And what she said was that care coordinators can go in, but it depends on the facility, if the facility's willing to let them in. I'm not going to pretend to know anything more than what she said, but
And even some of that is not everybody, and this is going to sound terrible, but I'm going to say it anyway. Just because the facility says everybody can't come in, they're not always right, because we all know that that's been a problem. They've been keeping everyone out and they need time to open the doors.
So
So
can some of that be added to the guidance? Things like, you know, the care coordinators need in, you know,
We
I know,
have.
I know what you're doing. I
They're
know.
staff. They're staff. I mean, it's in our definition of staff. That's what I don't, that's where I get confused. Because we've included those
We still
people.
get questions about, can the podiatrist come in? We're like, yes, for crying out loud. If you're diabetic and you need your toe, I mean, yes, you know.
I know, same thing
Some
with the
of
dentist, please, let them back
I
in.
know some of this has not been logical, but
Yeah.
it's everybody's frightened and people have died and it's a pandemic. We've never lived through this before. So I get it. But sometimes, like I say, if you're hearing stuff like that, sometimes it helps if we
Yeah.
can talk to somebody too.
Okay, that's probably enough on that one. We'll never get
Yeah.
through.
So,
Yeah.
can you explain how a family member should respond when a facility is in outbreak and insisting that a compassionate caregiver must wear an N95?
Good question. We have been saying that the compassionate caregivers need to be treated like staff. The reason we went there in the first place is we went there because the facilities were saying, well, they don't need to be in. And we're like, yes, they do. You have to let them in. You treat them like staff. So I can understand where that's coming from. Karen and I are going to have to take that back and talk about it because
But it goes, like I said, my issue is that they're not fit testing people.
well, here's the interesting thing about that.
They can do a seal check on,
June 10th, OSHA now put out new guidance, and they have something now called a mini respiratory protection program that doesn't require fit testing and doesn't require, but not for the staff. So that's why we have to take this back and we have to sort of thread how this goes. But
in all my years of acute care, when we had PAPRs, which is the purified air respirators, and we had all of the, N95 masks, et cetera. And with that, remember OSHA's for the employer protecting the employee. A family member is not their employee. So we offer that to them, but I can't make them wear it because they're not my employee. But we should provide them and show them how to do the seal check because you want to protect them as much as possible. So that's the education piece. And that should be documented on the care plan that I talked to Carrie to say, Carrie, this is something that you should be wearing to protect yourself from the virus. Your loved one has COVID-19. It is a respiratory virus. We need you to protect yourself. If you tell me to, whatever, I'm not wearing it, then I'll document that.
Right.
Right? I mean, that's how it should go down. I can't make Carrie put it on. I should offer it. I should provide her education, and I should explain the risks and benefits of that. But I'm not going to say you cannot come in and visit your loved one because you're not going to wear it. That should not happen.
and if it is happening, we need to know about it.
That's another, although, can I share one little quick thing? Somebody told on one of the webinars, what I'd never heard of this. One of the webinars, somebody, when I said that you need to be calling Deb and I, somebody said, snitches get stitches.
I must have
But we'll
missed that.
snitch. We'll snitch all you want, and we
But we
don't
don't care.
identify where it comes from.
Yeah. We
But I
won't say-
think also part of this is for people to realize that the information Stephen and Teresa put in at the very beginning is a link to your ombudsman. And you can call your ombudsman and you can say that you do not want to be identified. We will hold that to.
We don't-
we'll hold
We
that
don't
honor.
say where it came from.
That's
Yep.
all.
And so we can help be that voice as well. That's part of what we're here for. So everyone should, really remember that as well.
Thank you for that reinforced message, Lee. I do like the PSA right in the middle of the presentation. It's perfectly timed. Can y'all define first round of testing?
All staff, all residents.
Vaccinated or unvaccinated,
Is there a time frame for
other
that?
than the 90-day. That
Should
90
be within 48 hours.
Yes.
Should be. Is that documented anywhere?
Yes.
Or is that, okay,
Okay.
okay.
That-
Okay,
And
perfect.
that's why I said, I guess I didn't give you a time frame at the beginning, but we said that we felt comfortable with pausing indoor and outdoor during that time frame because our testing capacity right now is good. We can get that done within
Yeah.
1 to 3 days at the longest, but I mean, there should be no issue with that. So if
So
somebody
people are seeing-
or more, that is not, again, we need to know that.
Because we have been hearing people saying that it's 14 days now. They're going to possibly. Because one staff member in a building
And
got, tested positive, and
Just to see where it is.
Mhm.
And that's because if you've got 4 units and it's on all 4, we need to not have indoor on all 4.
Right.
But I don't think a lot of the facilities are hearing you when you say, okay, you didn't find it anywhere else. At least do your outdoor visits. Because I honestly believe they're not hearing that part. Because
And we'll
I'm still
clarify.
hearing
That's a good
14
point.
days, 14 days, 14 days.
Yeah, it's a good point. We'll make sure we
Say it again.
clarify.
You can
Right.
say it again.
Yeah.
Use the slides. Maybe we'll send them to everybody.
No,
Because
those
it does seem
slides,
like
Well, I tell you, that is why, Carrie, we're trying to incorporate that checklist at the bottom of the new guidance, because again, I know it makes it a lot longer, but it's do this, do that.
It's necessary. I use the slides. I put them on YouTube.
Well, yeah, and I took pictures of those slides. We do a Monday memo, and I would really love to incorporate that into that, so that way then all the ombudsmen will get that, as well as other people like Carrie that are on that mailing list for the Monday memo, and it will be I think it's a good checkpoint for all of us to be able to use them as a reinforcer. So thank you for sharing that.
And on the facility side of things, they're overwhelmed with all
and
that.
that's what I was just going to say. I'm going to give a pitch for these guys.
Sheets and things for them. That's what I call them, cheat sheets, because it's changing before they really get something else incorporated. It's like different again. And they're like,
They now have required CDC.
Friday webinars, they
Yep.
miss them occasionally. And if they miss one, they've missed it
Yep.
because things have been changing that quickly.
Yep. The other thing I was going to say is they have had new National Healthcare Safety Network, CDC required documentation, which takes a lot of time. You guys have no idea how much time this takes. June 10th, new OSHA guidance fell, and that's for anybody that has more than 10 employees. So say it's a group home, but it's part of a chain. So it applies to them too. So all of a sudden, they're having to deal with these layers of complexity that are necessary because of lessons learned from the pandemic. But the problem is people aren't getting vaccinated. We have situations where people are refusing to wear personal protective equipment, and they're refusing to follow the basic infection prevention rules. And a lot of times the facilities have to protect themselves from that as well. This isn't a circumstance where this is without risk. We've had over 10,000 people die in congregate care. This is not fake news. This is a pandemic. It is the virus that is the enemy. We are not the enemy. Nobody is the enemy here. It's the virus. It is killing people. I can tell you, I sat in and I'll get off my soapbox fast, but we have a vaccine that works. I've been vaccinated. My entire family's been vaccinated. My pregnant daughter-in-law was vaccinated and has a beautiful 3-month-old baby boy. But the thing is that there is so much cognitive dissonance. It depends on who you're listening to, some of the crazy stuff that is being said, where we have good, hard evidence that these vaccines work, that masks work, that social distancing works, that hand hygiene works. But when people refuse to do that, it increases the risk of people getting, and we've got these new variants coming in that if you're not vaccinated, those of us who are vaccinated and the residents have a pretty good chance of weathering this really well. But people who are not vaccinated, I say prayers for you every night. I will tell you, I say prayers for you every night, because people have to get out there and get vaccinated. This is not over by any means. We just happen to be in a lull, because we would normally be with respiratory. This is the time of year where your respiratory infections tend to be pretty low. But starting back into September, October, and November, we don't want to get into the same situation we were a year, last November. It's horrible. I mean, seriously, and I got to be careful because I'll start crying. Um, you know, you talk to people and their residents are dying, and these people work in long-term care because these are like family to them. And so we all have to work together. We really do. And we will try as much as we can to run interference, because I understand, but these nursing homes have had a lot on their plate as well. And I know you have too. Don't get me wrong, but we all have to work together.
And Deb, that's why we appreciate you being here today to help bring this conversation full circle, for everybody to be able to, because you're almost, I feel like you and Karen are like those independent parties that understand the story on both sides compassionately. Is there the next question?
So we're starting to get towards the end of the hour, and I found a few questions that I think I can just answer really quick. Kathy James mentioned that she can't get anyone to call her back to set up an appointment to visit. And Bernadine mentioned to email the request, and I agree with that wholeheartedly. If you still can't get a response, Kathy, call your ombudsman. There's a link to the ombudsman contact list at the top of the chat. And we can try and work with you and work with the facility to figure out what in the heck's going on. And if they're still not letting you schedule a visit, then call IDPH.
So go to the question about IDPH and the ombudsman, because that's an important question.
Is that Trish's question?
I believe so.
Okay. Trish asked, what are your suggestions for when a family member calls the Central Complaint Registry to report visitation issues, but are told to contact the ombudsman instead? Does this mean IDPH won't also look into an issue in addition to working with the ombudsman? Should they be contacting someone else to address this issue, since many times the facility is not interested in working with the ombudsman?
I don't know the answer to that one.
I don't either.
Because as consultants, Deb and I are consultants, I don't know the interweaving sometimes of contact people within IDPH. So
I could tell you that.
Lee or Carrie, whoever, if somebody would email us that question directly, I can get a response.
I will do that, but I can tell you that according to Becky Dragu, her answer to me is to tell everybody to file a formal complaint. If you call and they won't do it online, okay? And you're actually better off doing it online, in my opinion, anyway, because you've now done it in writing and you have documentation.
Mm-hmm.
It's
So
much better than a phone call.
Is that what you just said the right answer, Carrie, to that question?
I would say yes, that they should be, and there are facilities that are refusing to work with the ombudsman or refusing to work with me or all the rest. But that's why when you do it in writing, you can say, I've contacted my ombudsman. Here's my proof. I've done this. I've done that.
Okay. Because
then IDPH has what they need to start investigating.
Yeah.
And that's part of where some of this comes down to. The next question behind that was, what do we do about, there's a facility that's requiring family members to sign AMA paperwork just to walk their loved one outside to get fresh air or to go to the doctor. And they can't figure out why.
Yeah. And so Carrie, to add to what you just said, the Central Complaint Registry should be taking complaints and not passing them off to the ombudsman. So if you have that situation, Trish, make sure you're asking for the name of the operator that you're talking to, and make sure you write down the phone number, because there is the senior helpline that, in talking to people, sometimes they'll confuse the Central Complaint Registry with the senior helpline. And make sure you're talking to Central Complaint before you make a complaint about the telephone operator. But let's see, I think one last thing Julie Lewis commented, my father-in-law's facility makes us sign an AMA form for each time they leave, even for a medical appointment or a walk outside on the facility campus. Not really it was more of a comment.
I think it's a comment. I'd work with the facility. I'd talk to the administrator on that one.
Okay.
Well, see, here's an issue, and it did come up in a comment/question from Julie Schupner, who said, any suggestions on how to advocate for visitation that follows the IDPH guidance when the facility, and this is where I'm getting at that this is what they do, they have their own stricter guidelines that they are requiring of families to follow. So the resident and the family both vaccinated for a long period of time, no symptoms, no known COVID in the building for months, and the staff is requiring a separation by plexiglass, 6-foot tables being used, visits with face masks worn by everybody. And the resident may have some cognitive issues and doesn't understand, why do I have to wear this mask? What's going on with this weird clear wall? How do we talk? How do we have a visit? So the facility is not allowing any visits without the above mentioned PPE, and it's not allowing any touch.
And that's when you get us involved.
Yep.
That's when you get us involved, because those are the kind of things we can address, and that's where we can take it. We tell them there would be times where I would consider that close to an immediate jeopardy because of a resident's rights issue related to undue isolation, related to that is the same logic. You have to understand, I was a CNA in the 70s, and we tied everybody down with the lap robes onto not because we were being mean, but because we were keeping people safe. And it's that elegance of risk that you have to watch, but there are certain things, there's enough evidence now that probably was appropriate in March and April. It's not of 2020. It's not appropriate now. So those are the kind of things we need to hear about.
I like the phrase elegance of risk. I really do.
So I think that pretty well fills out our time. We're getting right at 4:00 here.
Oh, Stephen, before you send I was asked to kind of fill everybody in on what's going on with the federal bill before we let people go, so they have some idea where we're approaching right now. So there's a federal bill that's being introduced in DC on Wednesday of next week that will, if it passes, cross your fingers please and help us, that will allow every resident to have up to 2 essential caregivers under any health crisis. And it will modify the Social Security Act, so HHS can never issue another 1135 waiver to lock us out.
It makes it too. Humans always behave differently when behavior is observed. We all know that. But
Right.
also, too, you need to make sure that your loved one gets the appropriate support.
And hopefully this works. We have, I think, 7 sponsors so far. I actually get to speak at the Congressional Roundtable in DC on Wednesday. And I'm going to be begging people to help, because we will need people calling our legislators. This is our best chance. We've got to get this passed federally, and then we've got to go back to the state, because there are some facilities that will not fall under this guidance if they're not required by the Social Security Act. So basically anything that's private pay, we will have to get a law in every state also. And this is important, and this is our best chance. Deb and Karen all along have advocated for visits. They have been our best chance at IDPH, but they're 2 people. I have a loud mouth, but apparently it's not loud enough in the state of Illinois.
We always say there's 1,500 long-term care facilities and 3,000 SILAs. And I mean, there's a lot of places in this state, and there's 2 of us. So
yes. So, but just so people are aware where our next step is.
So there's a couple of takeaways, I think, just to kind of surmise what we've talked about today. First of all, Karen and Deb, thank you so much for taking the time. This is a very important group. I know I attend the Thursday calls and the Friday calls that you do with the providers and the providers of long-term care. And so to be able to talk to those that are the receivers of long-term care is a really important thing as well. So we truly appreciate you taking the time and your compassion for understanding where everyone is coming from. I do want to make sure that people reach out if you still are feeling your frustrations. There are links all at the top. I'm going to be staying on. I stay on until everybody leaves. I'm kind of like the last one at the party every time. So I will stay here. If I don't know the answers to those questions, we save that chat and we will make sure that's how we can get those answers. And some of the things I might be able to answer myself, but I won't answer if I don't know the answer. So know that. And I do want to also say that make sure that you do reach out to your ombudsman. There's also compassionate caregivers that Carrie works with in Illinois and that have really been strongly advocating for rights as well for people that live in long-term care. And I think we heard very clearly from Karen and Deb that we can reach out to you. If we need to. They put their contact information actually in the chat so that we can do that, because they don't know what they don't know. If we don't share information with them, they can't help us make the change happen as well that needs to be happening. And the last thing I think to say is, Carrie, if you can please make sure you put in there some sort of link so that people can know how to reach out to their US senators. This would be US, not state. You want to make sure that you're reaching out to your US representatives for this national, for the national bill that's happening, to be able to help support that and tell your Congress and senators at the federal level that this is something that's important to all of you as those who have loved ones or even live in a long-term care community.
So we have it on our Facebook page. I believe it's on our website, but I will double check. And our website is ILC4C. It's on our Facebook page, and we're just going to keep trying to share it. I will also make sure that the Ombudsman program has a copy of everything, so maybe that it can go out in the emails that come from the Office on Aging, and we're just going to start sharing it with everybody. Make sure you have the information how to get hold of the legislator and the bills and everything else.
Okay. Thank you.
I'm going to have to drop off for another
Yeah.
call. I will send you my PowerPoint slides.
Thank you so much, because we got a request for that. So thank you so
guys.
much, Karen. Thank you, Deb. We truly appreciate you guys being here today. Thank you. And I will be staying on. I'm going to end the recording now, and then I will be staying on if you want to put any of the questions in there. I'm seeing there are some people have emailed or chatted to me privately. I will answer your questions in a second. So I'm trying to get that happening. So thank you. Thank you, everybody. Teresa, Stephen, once again, Carrie, thank you very much. We got
And
a
I'll
great
stay with you just in case, Lee.
Okay, thank you.
Thank you.
Hey, Carrie, this is
Yeah.
Karen Kloppy. I just appreciate you sharing your info